Kras mutation does not complete the puzzle of non-responders. A significant percentage of patients who do not respond are negative for the Kras mutation. BRAF is another mutation. It's designated BRAF and it is present in the RAF protein group, which we see along the cascade, which we described before. It is present in approximately 8% of human malignant tumors, 50 to 70% of melanoma, 36 to 69% of papillary thyroid cancer, 5 to 12% of colorectal cancer, and 1 to 4% of non-small cell lung cancer. The clinical implications of BRAF are significant. We believe that BRAF mutations may have the same ultimate impact on poor response to EGFR status. That is because BRAF mutations are downstream stimulators of the RAS-RAF MAPK cascade. And once the BRAF mutation has been activated, the cascade is activated independent of EGFR status. BRAF mutation patients appear not to respond to anti-EGFR medications. This mutation may identify up to 15% of non-responders in the colorectal cancer group. As we look once again at the diagram, we see the location of the RAF protein complex. In this situation, the RAF protein complex has been permanently activated by the BRAF mutation. And consequently, the signals continue to the nucleus of the cell, spawning the types of cellular changes that we normally see in malignant cells. So we can say that right now, quite clearly, that BRAF and Kras are important biomarkers in patient selection of anti-EGFR therapy. It is true that additional markers are still needed for us to get a further complete handle on which patients will respond well to anti-EGFR medications and which patients will not. Now, there are additional applications for BRAF testing, which I think is important to note. The condition of hereditary non-polyposis colorectal cancer, or Lynch syndrome, is a significant issue for the diagnosing surgeon and oncologist who is treating a patient with a new diagnosis of colorectal cancer. In this condition, the patient has an autosomal dominant genetic condition, which means that family members have a strong likelihood of being affected by the same condition. Hereditary non-polyposis colorectal cancer, or Lynch syndrome, predisposes patients for certain malignancies, specifically gastric cancer, endometrial cancer, and other types of colon cancer. It is essential that a diagnosis is made with the initial patient in a family so that patients that are pre-symptomatic within that family can be appropriately screened. Unfortunately, the screening process involved in ruling out Lynch syndrome can be complex. Normally, there is a set of criteria which involve both the pathology of the cells combined with family history to establish the presence of Lynch syndrome. Unfortunately, only 40% of families with the mutations meet the Amsterdam criteria to help us make that diagnosis. Patients that do not meet the Amsterdam criteria involve a complex workup, which can be quite expensive and arduous. The BRAF mutation, if present in the tumor cells removed from the initial patient, excludes the possibility of Lynch syndrome or hereditary non-polyposis colorectal cancer. This is a safe, rapid, and cost-effective aid for laboratory investigation into familial colorectal cancer. Additionally, another cancer that we are concerned about is papillary thyroid cancer. Papillary thyroid cancer represents the majority of differentiated thyroid cancers. The mainstay of diagnosis for this type of cancer is a fine needle aspirant of a nodule of the thyroid. After an aspirant is taken from the tissue that is of concern in the thyroid, normally cytology is performed on that material obtained, and a pathologist makes a designation of papillary thyroid cancer or not. The problem is that there are many patients which have gray zone cytology, making it impossible to make a complete diagnosis based on that fine needle aspirant. By sending the cytology tissue for BRAF evaluation, it is possible to significantly increase the specificity and sensitivity of this analysis, making it much easier to make a call for papillary thyroid cancer, allowing patients to move forward with their diagnosis and move forward with appropriate therapy. In conclusion, Kras and BRAF testing are important in establishing appropriate patients for anti-EGFR therapy, and there are additional diagnostic advantages to both Kras and BRAF testing as well. If you are a physician, there's a wealth of information available in the literature. Additionally, as a patient, please contact your oncologist or surgeon to determine whether Kras or BRAF testing is relevant to your situation. It's been a pleasure spending this time with you.